Bismillahirrahmanirrahim. In continuation of our previous lecture, we are continuing with the thyroid gland, and I'm going to again revise about the anatomy of the thyroid gland. As you can see, uh, the bones and the structures. There, the cartilage, the hyoid bone, the isthmus. This is how the thyroid gland is located, and either side and connected with the isthmus. Uh, I can show you like this. This is how the larynx is situated, and right lobe of the thyroid gland and the left lobe and over the trachea and connected with the isthmus. I've already told you in previous lectures, and just a revision of it. And the veins mainly drained by the superior thyroid vein, middle thyroid, and inferior thyroid vein according to the corresponding arteries. The superior, inferior, middle thyroid arteries having the veins. Now we do get a question in the exam in the MCQs about the anatomical landmarks, and also that the superior thyroid vein drain into internal jugular, middle thyroid vein into internal jugular, and the inferior thyroid vein into the innominate vein. And the middle thyroid vein is the shortest, which has to be ligated first. So when we start with the thyroid surgery, so if someone asks you a question about thyroidectomy, that which structure has to be ligated first, so you have to say that the middle thyroid vein. And also, I want to tell you that whatsoever you want to tie, you should be very near to the thyroid gland instead of being away from it. So because if you stay near to the thyroid gland, so there are less likely chances of ligating a nerve or any other important vascular structure, or which you don't need to tie. Like you have to tie the middle thyroid artery or inferior thyroid artery very close to thyroid gland to avoid the ligation of recurrent laryngeal nerve. And same goes with the superior thyroid artery or superior thyroid vein. In order to avoid damage to the superior laryngeal nerve, we have to ligate it very close to the thyroid gland. So this is the venous structure. And coming to the next one, you can see the how the anatomical distribution of the veins and the arteries, and they are very helpful while you go for the thyroidectomies and dissecting the thyroid, how the branches are being given as the arteries ascend there, and how the veins the veins drain into the internal jugular vein. And this is basically the blood supply just for your VM. And this is the muscular uh, origin. I have already discussed about how the muscles are being attached. Now, a few diagrams of the thyroid swelling, just a preview of how you are going to find the patients in your clinical examinations, and in even OSPE, and in even the short cases. Uh, these are the ones in which we give for the short cases, and you are being asked to examine the neck, and you are being given the command of the inspection, and other are being the palpation, and then we take a short case of the thyroid gland. This was a patient in our hospital whom we later on treated. It was a multinodular goiter. You can just see that both the thyroid lobes are involved, and this was a very prominent swelling. And it was basically a retrosternal goiter, which we are going to discuss in detail in the later half of the lecture. This is also a patient which left-sided nodular goiter, and this is a multinodular goiter. You can see that the nodules all over the thyroid gland. So it could be a nodular goiter, a multinodular goiter, a solitary nodule, or uniform enlargement of the goiter, which is called goiter in sense. So this is also multinodular goiter more on the right side, and also the enlargement of the isthmus. This is how it looks like when we take out, and on the cross section or in the gross view, this is how the multinodular goiter looks. So they are both the lobes involved, and they are interconnected with the help of isthmus. This is how the gross section of a thyroidectomy specimen looks like. Now coming to thyrotoxicosis. Thyrotoxicosis is basically the excess production of the thyroid gland, thyroid hormones by the gland. You do come across the questions in your SCQs, the short essay questions, and also the MCQs about the thyrotoxicosis. And you also get questions regarding the treatment of thyrotoxicosis. And whenever there's a short case, so they are certainly going to ask you that how can you manifest clinically the signs of thyrotoxicosis. So this is very important, and you have to listen them very carefully because they are being asked repeatedly from the students, and any person who any student who is being given a case of a scenario of a thyroid gland. So it's quite likely that he or she would be getting question of thyrotoxicosis. So exactly what thyrotoxicosis is, the thyroxine production by the thyroid glands is increased either due to the whole enlargement of the thyroid gland, or which is called a goiter, or just a thyroid nodule. Sometimes it's just a very small nodule which is producing excessive hormones, and sometimes the whole gland is not producing excessive hormones. So when we classify thyroid, which is the enlargement of the gland, it could be either euthyroid, it could be either hypothyroid, or it could be even hyperthyroid. Not necessarily that an enlarged thyroid gland is producing excessive hormones. So we have to be very clear about this thing, that it's just not the enlargement of the thyroid gland which can cause thyrotoxicosis. Even a very small nodule can cause thyrotoxicosis, and even a normal thyroid gland with a very small enlargement can result in thyrotoxicosis. And on the other way, even a very large goiter could be having a picture of euthyroidism or hypothyroidism. So what happens is increase in the thyroid secretion and increase the response of body cells to adrenaline, and the signs and symptoms then occur. That what is we when we mean from the thyrotoxicosis. Now the clinical manifestation, what the patient is going to say to you. The first of all, the neurological symptoms. The patients are generally young age, manifestation of insomnia. They do come that they are having sleepless nights, nightmares, tremors in the hand and the feet, and they are called the rest intention tremors, and they do happen when they do want to work something. And for checking the purpose, you just have to ask the patient to just make you can see it on the in hands. They are warm hands, wet and with tremors. Nervousness is one of the feature. An anxious looking person with signs of nervousness, you can just judge by at a spot by the look at if he or she is having an enlarged thyroid gland and nervous. So they are all signs of thyrotoxicosis. The other ones are the cardiac manifestations. So in order to remember these things, you just broadly classify them either in a cardiac manifestation and neurological manifestation. Neurological manifestation would be central manifestation. That what I've just told you, that they would have been tremors, they would have been nervous, they would have been anxious, and the cardiac manifestation would be the tachycardias and the arrhythmias. They are very important manifestations in which the pulse would be irregular pulse, which is a classical sign of thyrotoxicosis. The other disease in which there is irregular pulse is atrial fibrillation. And the tachycardia is increasing the pulse. The patient who comes and complains that we can even hear our heartbeat, and वो ये कंप्लेंट होती है कि जी मेरा दिल बहुत जोर जोर से घबरा रहा है. So you have to look for the signs of tachycardia. Decrease in the weight in spite of the increased appetite. This is one of the main common complaint of a patient, that in spite of taking a good diet, they are continuously losing their weight. So this is also an alarming sign of thyrotoxicosis. And increased sweating and sense of hotness, even in the cold weather. There is a heat tolerance in thyrotoxicosis, but the people don't, the resistance towards heat tolerance is decreased, and even in the cold weather, they won't be wearing any extra garments to avoid the cold, but there would be excessive heat tolerance. Polyurea and diarrhea. This is one of the common complaints that the patient complains that they are being repeatedly using. Have to go to washrooms, and because of the polyuria and diarrhea and fatigability. This is one of the main complaints. When a person comes to you that even after doing nothing the whole day, he or she is having attacks of fatigability and malaise. So you have to think about the thyroid issue. Osteoporosis is one of the main issue also. People do come and the patients with the bone aches, and they say muscular aches and muscular dystrophy, and they all signs of weakness. Thyrotoxic goiter, one of the sign is the eye signs. Eye signs we are going to discuss later. They are very common signs of the eye about thyrotoxicosis. And the signs would be a lid lag, lid retraction, and exophthalmos. We are going to discuss in detail in the coming slides. So this is a patient of thyrotoxicosis, and now what we are going to see. Those were the symptoms which the patient is going to describe. That there would be two main systems involved. One would be the nervous system, other would be the cardiac system, and then the overall general activities of the body. And in the nervous system, there would be insomnia, fatigability, and tremors, anxiety. And in the cardiac symptom, there would be irregular pulse, tachycardia, and these sort of things. And in the rest of the symptoms, uh,